Hi guys, welcome back to my channel. I know I'm uploading this video after a long time. So, anyways, today I will discuss some important points of chapter number 16 of this oral pathology and oral medicine book by E.W. Odell and Cousins Essential of whatever. I have the hard copy. So unfortunately I don't have the PDF to share with you all guys, but today I will discuss only important points. I will not go further in details about this book and um, I'm just studying smartly then harder. So let's begin this chapter. So first of all, what are ulcers? Ulcers are discontinuity in the epithelial cells or epithelial covering of the body. And when the continuity of epithelial is breakdown. Then we have the traumatic ulcers. Traumatic ulcers are caused by biting, by any mechanical trauma, frictional trauma, and common sites are lips, buccal, denture, flange. A larger ulcer forms by biting after local anesthesia, and chemical trauma occurred by certain drugs like aspirin, silver nitrates, hypochlorite. Traumatic ulcers removed within 10 days, but if not removed, uh, in case if they are not removed in 10 days, so then we will go for biopsy. Then we have the next topic, eosinophilic ulcers, which are very deep, and the common site is tongue. Adults and infants are basically affected in this disease, and the location of this disease is the ventral side of the tongue or lower lip involved, called Riga-Fed disease. Riga-Fed disease is a disease um, which is basically what you can say is a rare condition in infants and characterized by ulceration on the ventral surface of the tongue. Okay, it's just a basic concept of Riga-Fed disease. Lesion heal within 3 to 10 weeks, and our next topic is factitious ulceration. Factitious ulceration is a self-harm or self-cause ulceration. So it is caused by cheek biting, etc. And common in the patient in the areas, non-healing areas, non-healing ulcers in the anterior mouth, which are easily visible, and we will do biopsy to exclude disease. And as I told you before, that it's a self-harm disease, and it's manifestation of medical condition like autism, familial dysautonomia. Okay, move on to recurrent abscesses stomatitis. Recurrent ulcers. So first of all, you need to understand the term recurrent. Recurrent means the ulcers which are resolved. First they are resolved, but they appear again. They reappear. So this is the recurrent form. Okay, so recurrent abscesses stomatitis clinical features are they start in childhood, and the reoccurrences increase in the adult life. Predominant symptoms are prickling or sensitivity at site for few hours before ulcer formation. Anyways, smooth, sharply defined with erythromatous rim. Minor abscess stomatitis is present on non-keratinized areas mainly. Size is 3 to 7 mm. 1 to 10 ulcers form at a time, and common site is labial and buccal. They heal in 7 to 10 days without scarring. Okay, alright. So let's move on to major abscess stomatitis. Major abscess stomatitis are Stomatitis location is non-keratinized. They occur on non-keratinized as well as keratinized area. Basically, they form on the masticatory mucosa. Means masticatory mucosa is also involved in this disease, and the size of this disease is like 10 mm size. Herpetiform abscesses stomatitis is the pinpoint ulcer, at least 100 ulcers present at a time. Present on the floor of the mouth, it present on the floor of the mouth, ventral tongue, and the areas which are non-keratinized. Etiological factors are so there is a box on 258 in your Cousin book. So there is written etiological factors, possible etiological factors for recurrent abscess: genetic predisposition, exaggerated response to trauma, infections, immunological abnormalities, gastrointestinal disorders, hematological deficiencies, hormonal disturbances, and stress. Yes, stress also. So, and immunological first, immunological abnormalities includes the autoimmune disease basically, and hematological deficiencies include the vitamin B12 deficiency and folate or iron deficiency as well. And in the hormonal factor in luteal phase of menstrual cycle, always remember that, and in non-smoking patients also. And for diagnosis, we will do first history and history of recurrent ulcer, detailed history on the shape, size, numbers, site, and duration. And we will do routine blood test for these patients. And management, we will do empirical and palliative treatment, education, corticosteroids, which includes hydrocortisone 2.5 mg 3 times per day, and triamcinolone dental paste, tetracycline mouthwashes, tetracycline capsule also 250 mg for 2 to 3 minutes 3 times daily. And the mouthwashes like chlorhexidine also involve 0.21 solution, and topical salicylate preparation, local analgesics, obviously to resolve pain. And we have the treatment of major abscess, cyclosporins, colchicine, and azathioprine. Then we will move on to the Behçet's disease. So it makes triad of oral abscesses stomatitis. This disease forms the triad. So it has the oral abscesses stomatitis, genital ulceration, uveitis, systemic uveitis. Then we have the systemic vasculitis in these patients also. The clinical features of Behçet's disease is like there is important gene involved, which is HLA-B51 gene involved. Male are more affected in this disease, and the age is 20 to 40 years. Oral ulceration is most common. Genital ulceration is also common. Joint involvement called arthritis, vasculitis in brain, and ocular problem, uveal inflammation. Etiology includes due to immune complexes, high level of cytokine secretion, activation of lymphocytes. Diagnosis and management includes the medical history, sterile needle puncture of a skin test we will do. So in this test, if the response is if we get the hyper reaction response, then the test is like positive. Always remember that. Treatment is very important for the theory stuff and for the OSPI or OSCE stuff or clinical stuff. So treatment is very difficult and require multidisciplinary approach to the patient. And we have the complication. Complication includes blindness, rupture of large vessel, and thrombosis, embolism. etc. Then we will move on to the HIV. HIV associated oral ulcers in HIV patient. Abscesses are major or herpetic form, and the treatment is potent or topical steroids. Nicotindel induced ulcers are caused by like we give nicotindel drug in heart disease. After 18 months of taking starting dose of these ulcer formation, these ulcers are basically formed. I hope you get my point. And ulcers are punched out, overhanging, and ranges 1 to 3 centimeter. Desquamative gingivitis is on page number 262 of your book. So basically it is caused by lichen planus and a well-defined band of patchy erythema extend across the full width of attached gingiva around several teeth. So I'm reading the figure 16.10 in Cousin. Basically, desquamative gingivitis is important, and you just need to remember it is caused by lichen planus. And you need to remember the etiology and pathogenesis also. Okay, we will not go further in details about desquamative gingivitis, although it's important, but you have learned this in your perio also. Anyways, we have lichen planus. Lichen planus is chronic inflammatory disease or autoimmune disease common in middle age, and it is more common in females than males. You need to remember this. Pathogenesis is cytotoxin T cells react against basal cell of epithelium and associated with hepatitis C virus. Skin lesions are purplish papules formed called Wickham's cystery and common in forearm, wrist. Treat with topical steroids, oral lesions. So then we will discuss oral lesions. Oral lesions are bilateral and symmetrical lesions present on buccal mucosa, tongue, lateral margin, or gingiva. On gingiva, there is also desquamative gingivitis, floor of the mouth or palate not involved. If involved, then chances of malignancy. And the types are reticular lichen planus. Reticular lichen planus have the meshwork of striae, form lacy radiating pattern, and the most common form atrophic lichen planus epithelial is thin as a thin red appearance of oral mucosa. Ulcerated lichen planus are shallow or irregular. Plaque form on dorsum of tongue or buccal mucosa. Desquamative gingivitis. 3 gingivas are involved but commonly attached gingiva. You need to remember this point. Bullous lichen planus is basically loss of attachment between basal cells and basement membrane. Epithelial cells totally separate from basal membrane and from bulla. And for diagnosis, we will take the history and do biopsy when plaque type lesion seen on the biopsy. And the management, we will give steroids and avoidance of spicy food and irritant and the things which are irritant to this disease. Then we will go on or move on to the lichenoid reactions, unilateral lesions due to any underlying cause. Most common drug. So there is a box in your cousin oral medicine book on page number 268. So this 16.9 box is important. Just give it a read. Then we have restoration, reaction, amalgam, lesions are dry or plaque-like atrophy also occur. Okay, let's move on to the lupus erythematosus disease. Lupus erythematosus is found both form in the systemic and cutaneously, and it's basically a butterfly rash in oral lesion and occur in hard palate caused by type 3 hypersensitivity unilateral lesion, while in lichen planus it occurred on the lichen planus occur on the hard palate. Hard palate is not involved in the lichen planus, if I'm not wrong, and in lupus erythematosus hard palate is involved, so there is a difference. Chronic ulcerative stomatitis. Okay, move on to the chronic ulcerative stomatitis. It is an autoimmune reaction against IgG antibody, common in females 40 years of age. Specifically, lesions are shallow ulcers or erosives. So there is a box on 271, page number 16.9. Okay, let's read this. 16.10 actually in my book. So there are key features of chronic ulcerative stomatitis. Females older than 40 years mainly affected. Lesions resemble lichen planus. Direct immunofluorescence shows an autoantibodies to squamous epithelial nuclear protein. Chloroquine or hydroxychloroquine moderately effective in this disease. Then we have the disease immunobolus disease, autoimmune disease also called the vesiculus bulla disease. The difference between the bulla and vesicle is very small. It is small while bulla is more than 10 mm. You need to remember this. And then we have the box 16.11 on page number 271. So let's read this box. The immunobolus diseases: pemphigus, pemphigus vulgaris, pemphigus foliaceus, IgA pemphigus, drug-induced pemphigus, paraneoplastic pemphigus, pemphoid, polys pemphoid, mucous membrane pemphoid, linear IgA disease, drug-induced pemphigoid, dermolysis, bullosa, acquisita, whatever, and dermatitis herpetiformis. Okay, so this is all for chapter 16. I hope I have helped you all in your notes. Best of luck for your pre-profs or finals, whatever the season is. And please like, share and subscribe to my channel.